morning. So I'll be covering briefly on the PET-CT in pediatric lymphoma and its role. So this will be the outline of my talk. I'll introduce the topic and speak on what is the role of F18 FDG PET-CT in pediatric lymphoma, with specific reference to staging, response assessment, the scoring systems that are used, and also the metabolic indices that are primarily used for prognostication. What are the challenges and limitations of PET-CT imaging, specifically in pediatric lymphoma, and the available recent advances? So we know that lymphoma is one of the most prevalent pediatric malignancies, and among the HL, Hodgkin's lymphoma, the nodular sclerosing type is the most common. But we know also that NHL is more common than HL in children, and the common NHL subtypes are Burkitt's and Burkitt-like, precursor T cell, DLB cell, and ALCLs. Indolent lymphomas in children are very rare, but we know that in the functional imaging that F18 FDG, fluorinating fluorodeoxyglucose PET-CT is now established as a reference investigation for pediatric patients who are diagnosed with lymphoma. So just briefly on the mechanism of uptake, we know that all cancer cells exhibit the Warburg effect, where they preferentially utilize glycolysis for energy production, even in the presence of oxygen, and that leads to increased uptake of glucose. So when we use F18 FDG, which is a glucose analog, it gets phosphorylated within the cell, but however gets trapped and does not undergo further cell metabolism. So it is accumulated in these cells of lymphoma. And on the left is the physiological distribution of F18 FDG. It's important to note that not all lymphomas are FDG avid. Majority of them are, like the Hodgkin's lymphoma, the DLBCL, the follicular lymphoma, mantle cell, and Burkitt's. The whole list is given there. But there is also the entity to remember that not all lymphomas, like the MALT or the marginal zone lymphoma, the CLL or SLL, splenic marginal zone lymphomas, or primary cutaneous anaplastic T cell lymphomas, these do not show FDG avidity that much. Only 50 to 80% of them do. So this is an example of how avid retroperitoneal nodes are found in a patient expressing good FDG uptake. Like I already mentioned, it is important to note that, that there are lymphomas like primarily the marginal zone lymphomas, the CLL, lymphoblastic lymphomas, and cutaneous T cell lymphomas, which do not express or accumulate FDG within the cells. So this is an example of a child with enlarged cervical nodes. We find that the uptake is almost normal. Okay, now moving on to the role of functional imaging of PET-CT. Where all is it useful in pediatric lymphoma? In the staging process, in treatment planning, especially to know where to biopsy from, if the child requires RT to delineate the RT volumes, and also looking at response assessment to look at restaging or recurrence detection and prognostication. So what are the specific things we look for in staging? Like we already know the Lugano classification. I'll just go through it. Stage 1 is when there's one group of nodes involved. It becomes 1E when there is a single extra lymphatic site in the absence of a nodal involvement. Stage 2 is when there are 2 or more nodal groups, both on the same side of the diaphragm, or it could mean 2E, where there's a contiguous extra lymphatic extension from a nodal site. This may be with or without the involvement of other lymph nodes in that same region on the same side of the diaphragm. While advanced stage is stage 3 and 4. Stage 3 is when there are nodes on both sides of the diaphragm or nodes above the diaphragm with a splenic involvement. 3 is again divided into stage 3, 1 and 2. This is divided based on the group of nodes, lymph nodes that are involved. So stage 1 is when there is splenic or splenic hilar node, celiac or periportal nodes involved. While stage 3, 2 is involvement of the para-aortic group, the para-iliac group, linguinal and the mesenteric nodes. Stage 4 is a diffuse disseminated involvement. It is not restricted to any extranodal organ. So it goes beyond that. It's particularly when bone marrow, lungs, liver and all is involved, we call it stage 4. So PET plays a major role in staging of the disease. Just a word on bone marrow disease involvement. We find that the pool sensitivity of FDG in picking a bone marrow involvement is quite high, as equivalent to that of a bone marrow biopsy. However, the specificity is low. So this has caused a shift of using bone marrow biopsies to establish involvement. Just doing a PET-CT would suffice in some of the cases. So coming to response assessment, there are several categories that are used to determine if the patient has complete response, partial response, stable disease, or progressive disease. So over the years, several criteria have come up. But what I want to concentrate on is the 5-point dual scoring system and the Lugano staging and the CT. So I'll just come to that in detail. So what is this 5-point scale of the dual criteria? So it is basically the uptake in the disease in comparison to the physiological medicinal blood pool uptake and the liver uptake. So score of 1 means there is no abnormal uptake in the disease. 2 is when it is lesser than that of the medicinal blood pool. 3 is when it's more than the mediastinum and less than the liver. And 4 and 5 is uptake more than the liver. How do we differentiate the two? 4 is moderately increased, more than the liver. But when it is 2 to 3 times higher than the liver activity, it becomes stage 5. 5 is again divided into A and B, where A is markedly increased uptake in a previous lesion, while 5B, there is a completely new lesion that has appeared. While X is a score where we see new areas of uptake, which is unlikely to be related to the lymphoma, like a pneumonia or a LRI causing a pneumonia picking up uptake. So that we have to score as X. So the time point scale that we offer at the end of interim PET is 1 to 3 is, it means there's a complete metabolic response. But a score of 4 and 5, we have to mention if it is 4 with a partial, no metabolic response or a progression. So both components should be mentioned in the score, not just if a 4 or a 5 score. We need to mention in terms of how the SUV has decreased compared to the baseline scan. While the end of treatment PET, a score of 3, we have to note here, is not complete metabolic response, but an indeterminate response. That is the only difference between an interim and an end of treatment PET. While 4 and 5 is the same, like I already mentioned, don't just mention the score 4 and 5, it has to be mentioned along with the change in the SUV, whether it is partial, stable, or a progressive disease. So why are all these scorings important? So in lower risk and intermediate risk group disease, when there is a score of less than 3 on interim PET, it is shown that we can safely omit the field radiation therapy to that involved field. It has no negative impact on the outcomes. Then there are also studies which say that with PET and the scoring, both at interim and at the end of treatment, there is a high specificity of predicting relapse. That is, higher the score, the higher the chance of relapse, and higher the chance of overall poor survival. There is also an entity called the quantitative PET, apart from the Deauville score, where this was looking at the QPET or the quantitative PET in pediatric lymphoma at the end of interim PET-CT, at the end of the interim treatment. The QPET is nothing but the quotient of the SUV peak of the hottest residual lesion divided by the SUV mean of the liver. So the cutoff was 1.3. So a QPET score of less than 1.3 would be an equivalent of a Deauville score of 1 to 3, and it would mean complete response. While if the score is between 1.3 and 2, it is equivalent to a Deauville score of 4, which meant either a partial or an indeterminate response. While a QPET score of more than 2 was suggestive, it was equivalent to that of the Deauville score 5, and it meant residual active disease. So this has been subsequently utilized in other studies after the initial validation. So moving on to what is lyric score. So in patients where immunomodulatory therapy is used, like nivolumab and all these kind of drugs, there is always a chance of pseudo progression where it appears that the FDG uptake is increased or new lesions have appeared without any clinical deterioration. So to overcome the confusion in the response assessment of these patients, the term IR or indeterminate response was introduced under this lyric criteria. And this was given to address such lesions which we do not know if it's true disease progression or not. So IR1 would mean an overall more than 50% increase in the overall tumor burden without clinical deterioration. While IR2 is differences, there are new lesions, but it is not suggestive of a more than 50% increase of the existing lesions. While IR3 would just mean an isolated increase in the FDG uptake. So there is no increase in the size or number of lesions. It's just an increase in the FDG uptake compared to the previous baseline PET. So if there are more than one pattern in the same patient, we have to give priority to IR1 and 2 over IR3. But what do we suggest as nuclear medicine physicians? What do we suggest to the clinicians is that if we have to really confirm it, we either do a biopsy of the lesion or a subsequent imaging within 12 weeks. to really confirm if it is a true progressive disease or not. So this is an example of a child who had come with mucocutaneous lymphoma on leronlimab. We can find that there was axillary nodes with SUV of 5.5, but in the subsequent scan, we find that the uptake is increased and the size is also increased. We do not have a follow-up of this patient, but this is just to show that on immunomodulatory therapies, there can be this entity of pseudo-progression, which we need to be careful while interpreting. So just summarizing what I've already said, the Lugano classification came up in 2014. Then came up the LYRIC in 2016. 2017 brought in this entity of CT-based response assessment, which is called the RESIL criteria, where it used the CT response of more than 30%. So partial disease in that case was more than 30% decrease in the sum of the longest diameters. So that was again divided into partial and minor response, while stable disease was a CT score of less than 10% decrease or more than 20% or less than 20% increase in the sum of the longest diameters. So this is just to note that in lymphoma itself, so many criteria have come up, but what we stick to right now is mostly the Deauville scoring and the LYRIC scoring. So just moving on to prognostication using PET. So we know that there are several metabolic indices which look at the semi-quantitative assessment while looking at response assessment and to assess the lesion activity. SUV, we know, is basically the tissue activity divided by the injected dose by the body weight. What is SUV lean or SUL? It is normalized to the lean body mass instead of the total body weight. So this reduces variability due to different fat content among patients. SUV max is what we most commonly use, which is maximum standardized uptake value, where we take the single voxel showing the highest SUV within the tumor or the region of interest. SUV peak, how is it different from SUV max? So this is when we take a fixed volume spherical ROI, usually 1 centimeter cube, centered around the area with the highest uptake. And you take the average value within that. That is SUV peak. And this is less susceptible to the noise compared to SUV max. SUV mean is nothing but the average SU within the defined ROI. And it gives like a global estimate of the metabolic activity. So what is MTV and TLG? This is metabolic tumor volume and total lesion glycolysis. So MTV here is basically the volume of the tumor which shows significant FDG uptake above a certain threshold. So it gives like the total metabolic burden of the tumor, while TLG is nothing but the product of this MTV into the SUV mean. So it represents the total glycolytic activity within that lesion. So it is not only combining the volume, but also the intensity of uptake. So what are the advantages and disadvantages of this? SUV max we know is most commonly used. The advantage is it is independent of the ROI size, it is reproducible. But the disadvantage is that it is susceptible to image noising, the uptake time, the scanner resolution. While SUV peak, though it is reproducible, it is not suitable for the small lesions, and we have limited software availability for that. SUV mean again is less susceptible to image noise, but however, there can be a high inter or intervariable observer variability. So prognostic indicators, MTV and TLG are far better. There are many studies that have shown that it is predictors or prognosticating much better than SUV max. So this is just to show how, it's not lymphoma, but just to show how MTV and TLG is representative within the image. So the total volume where FDG uptake is high, where SUV max is more than 2.5, that is given as MTV, and TLG is the product of the two, SUV mean of the total tumor into the metabolic tumor volume. But what is the drawback of these volumetric indices? Even though they're good prognostic indicators, there is no consensus on where the tumor starts and where the physiological uptake ends. So we need dedicated softwares. It's quite time consuming to come up with the actual assessment of these volumes. So that is the main drawback of these two indices. So coming to some of the challenges we find while interpreting pediatric PET-CTs, there can be many sources of false positives, like a patient had a recent URI or infections. You can have a lot of cervical nodes because of that. The Vellore ring. So areas of physiological uptake should not be misinterpreted as disease, especially in thymus and in the Vellore ring. Brown fat, presence of splenic and bone marrow uptake post-treatment. And some, like I already mentioned, not all the tumors are FDG avid. So that again should be interpreted with caution. Motion artifacts can be there, especially in children who need sedation for doing the whole procedure. And radiation exposure in children, we know that they are highly radiosensitive, so that needs to be kept in mind while doing PET-CT imaging. And also, like I mentioned, specific cutoffs for MTV and TLG, we do not have universal established ones. So this is just some images showing how adenoids can show symmetrical uptake. Up to an SUV of 3 to 10 is acceptable if it's in a physiological tissue. But when there's focal uptake or mass effect, that needs further, warrants further ENT correlation or MRI. It's important to know that recent infection and vaccination can also increase uptake. So palatine tonsils, up to SU of up to 6 to 8 is acceptable, and if it is symmetric. But when the SU max increases more than that, an SU of more than 8 to 10, or if it is focal, or if there is a lateralization of the uptake, then that has to be considered more in favor of a disease rather than physiological uptake. Here again, reactive nodes should be kept in mind, which is common in children and should be interpreted with caution. The presence of brown fat, very commonly seen in the cervical and supraclavicular regions, axillary regions, paravertebral regions. So especially when there's high brown fat in the areas of cervical nodes, we need to be careful while looking at the images. Again, thymus, physiological or rebound thymic uptake, when it's diffuse, having smooth margins and SU within 4 is considered physiological. But when it's focal or heterogeneous, when it exceeds SUV max, usually more than 4, we have to raise suspicion. Bone marrow uptake and splenic uptake is very commonly seen post-treatment, but whenever there's an asymmetrical pattern, it's more likely to be pathological. And when the SUV is much higher than that of the liver, it is more in favor of a pathological involvement. So just moving on to some of the recent advances in PET imaging and lymphoma. PET-MR has been coming up in a big way. It has significant radiation reduction because it omits the CT dose to the child. It has high agreement with PET-CT in staging. But however, it may have some lower sensitivity for some of the response lesions. So that may be something to keep in mind. And not all centers may be able to do this. Coming to volumetric metabolic parameters like MTV and TLG, like I mentioned, it is definitely better for prognostic stratification. But the drawback is that it has the lack of universally agreed threshold segmentation or definitions. So because of these differing cutoffs, it may still need prospective trials for further validation. Then total body PET, total whole body PET, which is large axial field of view PET-CTs, is very useful in children because the scanning is done at a much lesser time, much lesser patient radiation is there. And it also has improved detection of low lesion contrast or small lesions. So it is a very promising entity in pediatric lymphomas. But however, it is expensive and it still needs standardization, clinical validation. The use of AI tools, radiomix and automated AI tools has been showing promise to predict histological subtypes and for early response and relapse risk. But however, it again needs more further investigations and harmonization before it can be clinically adopted. And often other newer traces like chemokine-based receptors imaging is an emerging tool for lymphoproliferative disorders, especially because it has a theranostic partner as well. But even this remains investigation. Thank you.